Hi, everybody. I think I'm going to try and get started so that we can keep everything running on time. My name is Jen Steen-Revis. I'm one of the Komen Committee members, and I work at Compass Oncology as one of their breast cancer nurse navigators. I'm also a 12-year survivor of breast cancer. So welcome to the session today. Very excited to have you here. I'm going to be able to introduce our speaker here in just a little bit. I would like to go through some housekeeping items first. And I don't have a good memory like Dr. Dunham or Dr. Chandra, so I'm just going to try and read off of this. Restroom location right outside in the little circle area over here. CEU credits, if you're an imaging technologist, you have to sign in on the form at the front of the room. There's exhibitors in the ballroom, research posters, merchandise, and photos next to the ballroom as well. There's some index cards, and Thais is our session assistant today, so if you have any questions about today's speaker session, please go ahead and write down your questions on the index card. She can pass them down on the rows and then hand them down to the end of the side, and we'll have about 15 minutes to answer any questions. Complete the general and session reviews. Hopefully all of you had in your packet that you got today the evaluation forms. Just make sure that all of those are filled out by the end and turn those in before you leave today. That would be really helpful. And let's see, do we have anything else? I think that might be it. So today I'm very excited to introduce Dr. Ravi Chandra. He works at Compass Oncology actually with me. Dr. Chandra serves as Medical Director of Radiation Oncology at Compass Oncology. He's skilled at delivering all types of adult radiation therapy, including stereotactic radiation and brachytherapy. He's published extensively in the fields of clinical and translational research, including a recent publication in Science Translational Medicine. Dr. Chandra is especially interested in breast cancer treatment, having trained under Jay Harris, Alphonse Tagian, and Abe Recht during his residency at Harvard. In addition to his local work, he sits on the Radiation Oncology Executive Committee at U.S. Oncology, as well as additional committees focused on clinical excellence and new technology adoption. A West Coast native, he received his undergraduate degree from Stanford University. He then obtained a PhD in chemical biology at UC Berkeley prior to his MD at Johns Hopkins. When not working, Dr. Chandra enjoys spending time outdoors with his family, good food, and coffee. And now please help me welcome Dr. Chandra.
Thanks so much, Jen. It's good to be with everyone today, and thanks to the Komen board for including this very timely topic. Is there anything I need to do for the... So I think this actually dovetails pretty nicely with Dr. Dunham's talk regarding the concept of choice and decision-making when it comes to breast cancer treatment as well as the use of radiation. And it's a timely topic in the sense that we have been seeing sort of an uptick, I would say probably by maybe even 200 or 300% in the number of women who are coming back who have either a second cancer or a recurrence in the same breast that was treated before, and trying to understand what the options for them are. So I wanted to spend a few minutes today talking with you about some of the data, but just sort of the big picture regarding what those options are. Kind of while we wait to get the slides going here, can I just kind of get a sense for, in the room, how many folks are survivors or patients? Okay, and how many folks are practitioners, either in oncology or a related field? Okay, so most of the slides, unlike Dr. Dunham's, do have a lot of numbers in them, and based on her talk, I would say that taking some time to go through those numbers at a later date is probably the name of the game. So really, we want to sort of focus on kind of the big picture and use the slides as sort of go to sleep material later on. So anyway, I'll just go ahead and jump in, and then once we get the slides going, we'll sort of pick up where we are. So basically, in breast cancer, as Dr. Dunham mentioned, when you have a breast cancer, typically if it's early stage, you have, broadly speaking, sort of two options. You have the option for what we call conservative surgery, breast-conserving surgery, where we do a small, localized scoop out of the disease, which is followed typically by radiation. The alternative is mastectomy. So the classic teaching sort of had been that once you had radiation to a breast, that you couldn't do it again. And as treatments are getting better, women are living longer, we actually are seeing patients who come back with a second cancer, thank you so much, a second cancer in the treated breast. And the question is sort of what to do. And the textbook, if you open up most breast cancer care textbooks, will say these women need a mastectomy. And I think in the same sort of way that the Halstedian mastectomy has evolved over time, I think there also is a desire, largely patient-driven, but also on the part of practitioners to say, are there other options for being able to take care of these women? So the overall objectives are listed here, and really wanted to focus on the recurrence for early stage breast cancer. I'll touch a little bit on how we manage recurrences in more advanced stages, but really the focus is meant to be on early stage breast cancer. And sort of as we sort of saw in the previous talk, that we have made some progress in how we manage breast cancer. This actually is attributed to a Dutch artist from the 17th century, and women certainly have a little bit more choice and hopefully a little bit more of a pleasant experience than perhaps this woman did. For those of you who are practitioners, there's a really good review on UpToDate on the management of early stage breast cancer recurrences. And I'm not only indebted to it, but I also would point you to that for reference. Sorry, in your packet are some of the abbreviations that you'll see on the subsequent slides. We'll kind of go through them. But again, the big picture being that the terms that I think we really want to focus on would be the breast conservation, which basically means lumpectomy and radiation, and then some of these other terms regarding what we call in-breast tumor recurrence. So in general, when you have a second breast cancer or a recurrence, they can either be what we call local, which is in the breast that was treated. They can be regional, meaning that they're in the lymph nodes, or they can be distant, meaning either at a site that's not one of those or a combination of any of the above. And so over the years, as chemotherapy and other systemic therapies have improved and really made it so that people, because what cancer patients die of is not really the disease that's in the breast, it's the disease that spreads elsewhere, right, and impacts other organs. That as we improve the control of disease elsewhere, the question of what to do locally increases in importance. And as systemic therapy has improved, we start to see more of these local recurrences that we didn't see before because patients died of other factors. And we're also using more systemic therapy in patients who have larger tumors to try to get them to more conservative surgery. And the question is, does this impact whether or not patients experience a recurrence? We're using more conservative radiation techniques. Does that play a role? And of course, patient choice selection and other tumor factors are critically important. So I won't go in too much to the anatomy, but I think the things that are sort of the big takeaways from this slide are that the breast is sort of serviced by a highway system of lymph channels and lymph nodes. And of course, the term for sentinel lymph node and axillary lymph node dissection is known. The axilla is the area in the underarm. And breast cancers, as most people in this room know, like to sort of hitch a ride on the lymphatic system to kind of get out of the breast. And that gives us important information regarding the stage of the cancer, but also how to treat them. And the reason I bring this up is I just want to actually give you just a sense geographically for where the regional lymph nodes that are at risk are, both in terms of how we think about treating breast cancer, but also in terms of where recurrences may land. So when we talk about the axilla, that's this area. When we talk about the supraclav, that's this area above the clavicle. When we talk about the internal mammary nodes, those are the ones that are listed here. So over the years, as surgery has improved and we have surgeons like Dr. Dunham who are specifically trained in breast surgical oncology, and that's all they do, they focus on breast cancer, the rates of local recurrence have dropped significantly. So by each 10-year period, you see that our surgeries are getting better. Mastectomy, the data are a little bit, are probably also on the same scale as well in terms of the improvement with surgery, but are a little bit more variable depending on what study that you look at. But overall, the general figure is that a woman who has treatment for early stage breast cancer, approximately 1 in 10 will experience some sort of local regional recurrence, either recurrence in the breast or elsewhere. I think as with each passing year, that number will probably go down, but this is not an esoteric type problem. This is a real problem that we see. And certainly if they have conservative surgery initially but don't have radiation, we do see an increased risk of local recurrence. typically recurrences after breast-conserving therapy, so radiation and lumpectomy, or lumpectomy and radiation, tend to happen later than after mastectomy. And with the increased use of tamoxifen and other adjuvant hormonal therapies, we are starting to see these recurrences later and later. Whereas recurrences post-mastectomy are typically diagnosed by exam because, of course, we don't do routine mammograms on these women. In breast tumor recurrences in the treated breast are typically diagnosed by mammogram. And typically, if it's a new second cancer, the prognosis is better. And they can be a mixture of both DCIS and invasive cancer. Typically, they're invasive if the prior treatment was for invasive cancer. And 3/4 of the time, those recurrences happen in the breast with a mixture of the other sites I mentioned before. Some sort of terms for how we think about this is that true recurrences will occur in the same site that the surgery was initially, whereas what we call a marginal miss may be just kind of right next to where that surgery was. Remember that the breast itself, we sort of think about in quadrants. So it's kind of like if you divide the breast into kind of 4 different quadrants. Most of the recurrences occur in the same quadrant that the original tumor was and the original surgery was. And I sort of mentioned this before. Now, women who have new primaries versus recurrences tend to do better from both a disease and survival perspective. And you can see these numbers here. So disease-specific survival, which means survival related to breast cancer at 10 years, is 77% if you have a new primary versus a recurrence is 26%. So it gives you a sense for kind of how people do and kind of what the difference is. So what are some risk factors among those 10% of women who may experience a local recurrence? So whether or not they had prior radiation is probably the biggest risk factor. So if they didn't have it, they're at a much higher risk for a local recurrence. Now remember that radiation and chemotherapy themselves do have a very small risk of causing another cancer. And so I put a thought question here of, is the prior exposure to radiation potentially a risk factor? And though it's a small risk factor, but because unfortunately breast cancer is as common as it is, it's something that we do see, that women who have had prior exposure to radiation, either for breast cancer or other diseases, may have another cancer that happens to be in the breast. Initial margin status, so again, how much healthy tissue is scooped out originally, and then some other factors listed here that you might expect. So typically younger age cancers tend to perform worse than older, increased tumor sizes, higher grade, how angry those tumors look under the microscope. I list here separately that genetics and the presence of LCIS are controversial risk factors for local recurrence, and I wouldn't really sort of draw too much from those. So prognosis. So typically, if the recurrence is confined to the breast or kind of just around it, those women tend to do better than if they're up in the supraclav, that area in the neck, or in multiple sites at the same time. Now, as you would expect, if these recurrences happen very quickly, that means that our initial therapy probably either wasn't performed adequately or B, wasn't as effective in that individual. And then, of course, some of these other factors, larger tumors and other factors listed here portend sort of a poorer prognosis than if you don't have these. So how do we manage these patients, right? It's the same sort of pathway that you'll typically see in a new diagnosis. Mammogram is usually the first, and remember that mammogram is our most common screening tool after breast-conserving therapy, right? Breast conservation therapy. But prior radiation can make that exam via mammogram a little bit less reliable than if you haven't had it. MRI is controversial just because that breast, after having surgery, radiation, potentially other treatment, may have some other funny business on the inside, right? And there may be some false positives there. For the practitioners in the room, this is an important point, I think, is that inflammatory breast cancer or skin involvement can still occur and sometimes get misdiagnosed as infection or other sort of sequela of treatment. And it's important to keep that in your mind because you can see recurrences in that way. And of course, evaluating the axilla is important. We of course need tissue. We need to figure out what the status of the disease is. And so as I mentioned at the sort of the introduction, that mastectomy really is our standard of care. It's sort of the textbook answer. And virtually all of these women are able to get it if they need it, even if they've had prior radiation or prior treatment. But I think it's really the second point here that's the motivation for this talk. And And that is that the teaching is the reason we need to do a mastectomy is because we can't do radiation again, or this is your only option. And I think the important takeaway, if you take away nothing else from this, is that it is possible to do radiation a second time. It's possible to do it safely, and there are good data for it. They're more maturing data because this is an area of active interest. Now this little map here, and it's probably hard to see here, you can see it better in your slides. It's sort of dirty data. What this basically is are data for women who get a second surgery after initial lumpectomy. Now there are a bunch of reasons for that. It may be because they have positive margins and other things. I only put it up here just to mention that there's a pretty big regional variation in terms of the number of women who get repeat surgery. And so I think a lot of this also, a lot of this topic area is very regional. And that's something I think to keep in mind. So I list here sort of a whole slide, and I don't really want to kind of dive too much into it, but just to say that there are numerous studies that have looked at women who've had mastectomies and how they do. And so what you see here, this is how long we follow those patients. So we follow them for a good bit of time, what their local recurrence rate is and what their survival is. And not all these studies looked at everything, so that's kind of where some of these empty blanks are. The point that I want to make here is that the women who get a mastectomy after a in-breast tumor recurrence are not totally free of a subsequent recurrence. So it doesn't mean that the mastectomy in this situation is your savior. Now, obviously, if that's the choice that's best for you, that's good. But the point is that we need to look at these numbers and say, well, because these aren't zero, are we potentially able to consider other options as well? Now, I just want to touch very briefly on, there are some women who get a mastectomy who still need radiation after recurrence, so the second time around. Now, obviously, if they haven't had radiation the first time, it's less of an issue, but if they have had radiation, it can be delivered again safely, and they're good data for it, and we do see it. But that is something that you're not totally free of the need potentially for radiation in this situation. For some of the practitioners, I've just kind of listed some of the reasons why you might consider radiation to the nose or to the chest wall after post-recurrence mastectomy. Again, larger tumors, lymph node involvement, gross residual disease, these are all potential indications for giving radiation afterwards. So my list, and this again is just me, but I think if we went around the room, everyone could kind of list off sort of their own list, but what are some reasons why we might want to consider doing repeat conservative surgery? We talked about the first point, that we're seeing these more now than we used to because patients are living longer. It's a good problem to have, but it is a problem that we didn't used to have. Psychosocial factors, preferences, which really gets down to that shared decision-making that Dr. Dunham so eloquently spoke about. Mastectomy reconstruction may not be feasible, either due to patient factors or due to cost or other factors there. So, just kind of taking a step back, is local treatment even a possibility? And I mentioned to you, of course, that it is, so you know the answer. So in one of the studies that Dr. Dunham mentioned from Bernard Fisher, the NSABP study, where they looked at women and they were starting to think about using more conservative surgery and using radiation, a study called B06, which is kind of one of the seminal studies from back in the day, looked at mastectomy specimens. So they basically took the breast out and they kind of cut it up in four and say, okay, well, I have a tumor in this spot. How many of these women actually have other tumors there, right? So it's sort of like saying, forgive me for the analogy, it's always the analogy I use with patients, but just because there are a bunch of women in the room, I will say that I sort of analogize the breast to an apple, right? So if you have a rotten spot in an apple and you want to eat it and you're trying to scoop out that little rotten spot, what is the likelihood that because there's one rotten spot in one spot that there's going to be something in another part of the apple? And so for these women, it actually turned out that only 14% on this study had multicentric disease, meaning they had disease in other parts of the breast, other parts of the apple. Now, a lot of these women did not have radiation, which is different to the type of patient that we're talking about, but it sort of motivates the fact that this is not a crazy concept. What we know is that repeat breast-conserving surgery patients, so if you have a second lumpectomy, you still are at risk for yet a third recurrence. But what has been shown is that people who at least initially got excision alone when they got a second cancer, while they remained at risk for a recurrence, had the same survival as patients who had the bigger surgery. So that kind of motivates that if they're living the same length, could we do less surgery? And so this paper here was sort of the initial, or one of the initial experiences with the use of what we call wide local excision, sort of conservative surgery for in-breast tumor recurrence. And not going into the details, but suffice it to say that in this small cohort of patients, this was reported in the sort of the mid-80s, that 52 patients of the 118 or the 1,200 patients that were treated initially with breast-conserving therapy experienced a recurrence, and then just had an excision. So they had no radiation afterwards. Of those 50 people who just had the surgery alone without radiation, 12 of them subsequently went on to have another recurrence. Now that tells you, even without radiation, that approximately 40 out of 50 had no recurrence. So that's actually pretty encouraging. And then of the 12 people, that very small proportion that had another recurrence, virtually all of them could be salvaged meaning effectively treated with another procedure and live just as long, which is basically what this table on the right sort of says. Now, these data were smaller tumors, and it was a good experience, but it sort of foreshadowed the idea that we might be able to do less. And then over the years, this is some retrospective data, meaning data from patients that were treated in the past that we look back to kind of see what were, if we take a group of patients who were treated in a certain way, what are sort of factors among those patients that are more prevalent than patients who didn't. Now, of course, getting back to the issue of bias, there is what we call selection bias, right? There are patients who are probably more favorable are the ones that were treated. So we always have to kind of look at data sort of in hindsight as a little bit of, with sort of a little bit of an arm's reach. But anyway, there are some data, and this was one of the more recent, bigger studies, looking at people who had just excision alone. And these people did very well. So they followed them for 14 years, and they had similar overall survival compared to those who had mastectomy. You can see on an absolute basis the number's a little bit lower, but these weren't statistically significantly different. Their rates of local recurrence and distant metastasis were similar, both about 7%. These here, and you can look at these later, but these were some of the risk factors for getting a second recurrence. I think the points I would make here would be some of the things that you'd expect, right? And I showed you earlier, tumor size, hormone status, but this kind of gives you a flavor for the women who went on to experience a second recurrence. What were some of the initial, treatment factors that were impacted? They also went in, they looked at what was the risk factors among those women who would have not just one tumor, but more than one tumor. And there were only a few things that sort of came out, but the women who had larger tumors, so in this case, you can see here, as the tumors got larger, the likelihood that they had disease in more than one spot increased. The likelihood that it was detected both by physical exam and mammography was also impacted. So meaning if it has to get big enough for you to feel it, right? And then there were some other things too in here as well. I think there was the BRCA1 and 2 mutation also. So the largest series that we know, kind of looking back on women who had conservative surgery after initial breast conservation, comes out of Milan. And these were about 57 women who were followed for 73 months. And you can see that their survival is very similar. The local recurrence rate is higher than if you had mastectomy in this group of patients. But this is the same sort of table I showed you for the mastectomy, but now just for excision alone. Remember, no radiation. And saying that while these numbers are higher, they're not on average significantly higher, that this is a totally crazy approach, right? But it does motivate the fact we need to do something maybe a little bit more than just surgery on the second round. But importantly, this column shows that survival-wise, those numbers are very similar to the other one. Okay, now importantly, we don't have good data in a lot of these studies on margin status and what the tumor looks like under the microscope. And this is important because you want to make sure that you're comparing apples to apples when you're comparing the mastectomy versus the conservative surgery. So while we sort of hold these at an arm's length, it foreshadows the development of trials that are looking at this question. So the things that I want to conceptually sort of distinguish for reirradiation is, are we reirradiating the whole breast, right? So most women who have breast cancer surgery initially, who then go on to get radiation, get treatment to their whole breast, followed by zooming into the area of the lumpectomy, something we call a boost, and get a little bit more dose there. But when we re-irradiate, do we re-irradiate the whole breast? Do we re-irradiate just the area where surgery was? What about the lymph nodes? And there are data to suggest that doing a whole complete second course of radiation is feasible and safe. And I'll show you some of those data. But it's really not recommended just because the risks are definitely higher than the first time around. There is certainly a risk of tissue injury and other structures in the field. That there is the increased possibility of injury. But so then that sort of motivated the concept of, well, what if the second time around we just treated the area where the excision was? We knew from those studies that those women did just as well, meaning that we're probably not needing to treat the entire breast because those women are sort of at lower risk for what we call multicentric disease, right? The idea that it's in other quadrants of the breast. So what if we just focus on the area of the excision? Could we bring those numbers that were in the high 20s to low 30s down to the rate that we see with mastectomy? So that's where the advent of re-irradiation partial breast, the idea of treating just the re-lumpectomy area plus a little margin came to be. Now, many of the same decision-making that we use in terms of thinking about women who are not suitable for breast conservation the first time are the same contraindications that we would have the second time. So if for some reason they couldn't get radiation or there were other potential contraindications. So one of the biggest studies looking at repeat irradiation I've shown here, and I've shown some of the data here on the subsequent slides. And basically, what you see here, we won't kind of dive too much into it for the sake of time, but on the left here, if you look at it later, are some of the details of the patient's first course of radiation, and this was the second course. And the thing that I really want to kind of draw your attention to is the dose range. And for those who are aware, this is a pretty significant dose range distribution. But the fact that women could potentially get up to 70 gray on the second time around is actually pretty crazy. Actually, not crazy in an unsafe way, but kind of crazy interesting. Anyway, radiation fields also, there was a good distribution of whether we're treating the whole breast or the partial breast. Some women were getting it twice a day. But notably, most women tolerated this pretty well. And using this as sort of a proxy, how many women needed to take a break right during treatment? It's actually pretty uncommon that patients need to do that. And actually, what was nice to see was that patients did pretty well. Some of these data give you a sense for where those sites of recurrence were in the second time around, where we expect. The most common site is either the chest wall, followed by the breast, and then the nodes. But what you see here, and what we do for those who are not practitioners, is we grade toxicities on a 1 to 5 scale. And so 5 is dead, and 1 is very minor. And then you can imagine in between. And so we grade them both on the acute basis, so during treatment, and on the long-term basis. And there's always a distinction between what the patient reports and what the doctor reports, right? Because you would think there may be a bias, right, for doctors to report a lower. And so it's always good to sort of juxtapose both of those. But so the higher grade tends to be worse side effects, and these are different medical terms for things that could potentially be impacted. I think the point is that very few patients among this large series had any major side effects from the second treatment. And even among the minor side effects, the grade 1 side effects, it actually was a very small proportion of patients who actually had skin effects. So I think the things that we get most concerned about, aside from sort of long-term damage, are what are the cosmetics of doing it a second time? Is there potential for scar tissue or other skin or tissue-related injuries? And this paper, I think, really showed that it's a pretty well-tolerated treatment. These are some more details as to what the variables of the second course were. And on this side here, these were variables that were sort of looking at how well those patients did. And so I think what's sort of interesting that kind of came out of this is that all the ones that are significant, meaning the things that are important, are the ones where the p-values are less than 0.05. And so I've listed a few here, but women, this kind of gave us sort of an indication for the threshold dose of what we need to treat the second time to in order to see better outcomes. That women who had a longer period of time between their 2 courses, so meaning women who didn't have a second issue right away, but there was some time, did better than those who didn't. And there's some other things here too, whether or not, and I'll sort of allude to this at the end if we have time, regarding the use of chemotherapy. But a lot of these other things that might be, these are sort of the the sort of areas of interest that the people think might be sort of a variable, right? So does increasing the dose more cumulatively matter? Does doing it twice a day matter? Does the type of radiation we use? And these things didn't really seem to be significant in terms of how patients did on the long term. So basically, I think overall, certainly if they didn't have radiation the first time, giving radiation the second time is very safe and should be done. But then the question is, what are the sort of ideal types of women that you would want to treat with this on the second go-around? And so one suggestion is looking at women who have smaller tumors who are generally 4 or more years after treatment. I tend to treat women a little bit earlier than that, but in this review, the people who had smaller tumors that presented later seemed to do better than those who didn't. Okay? And then obviously, patient preference is a significant factor. Now, if there are positive genetic mutations, BRCA or otherwise, or other risk factors for multicentric disease, we have to be cautious. It's not what we call an absolute contraindication, meaning a total no-no, but it's sort of a no-no in lowercase, right? And that's really sort of a discussion you need to have with primarily your surgeon and your other doctors regarding what are the risks and benefits of doing one versus the other. So what are the options for being able to give what we call partial breast irradiation? So I'm going to list all of them here. I'll show you some pictures at the end, but so to give partial breast irradiation, what we most often do is what we call external beam-based, right? It's a radiation that a lot of the people in this room may have had, right? So it's X-rays from the outside, and we can give that to just a small area. There's a concept called brachytherapy, and we have some experts in the room on that as well, where we can put the radiation right close to where we need to treat. And we can use catheters, which I'll show you, which are just plastic tubes. We can put in seeds. We can put in balloons. And those are just another way of being able to give partial breast irradiation, just another technology. But it's the same basic idea. You can also give it intraoperatively. So patients asleep, we wheel in a radiation machine, and we give the radiation while the patient's asleep. And that depends a little bit on surgeon and radiation oncologist preference and technological availability. There's some pros and cons there. Hyperthermia I'll make mention of. It's a technique that we don't often talk about, but what we actually know is that with cancer cells, when we actually get the temperature up, so above 43 degrees Celsius, they are more susceptible to damage. Basically, they're more susceptible to cell death. And so there has been interest in using hyperthermia in conjunction with other techniques to sort of maximize the kill of tumor cells. And there are some data there, but the side effects are a little bit higher. There also are studies looking at the use of protons, which are a special type of external beam radiation. The concepts and I think the outcomes are very similar to normal external beam based, but it's just a different sort of technology of giving external beam partial breast irradiation. So what are some of the experience with giving radiation the second time? So at my old stomping grounds, in 1989, there was a patient who, and this was just a case report of one patient, so really not a lot to hang your hat on, but anyway, so it was a patient who was treated with whole breast irradiation, subsequently went on to get a wide local excision, so basically a lumpectomy. And they got some seeds, so some iridium seeds that were put in. And that's just sort of effectively partial breast irradiation. And she died of other causes 72 months later. Subsequent reviews of looking at conformal radiation shows acceptable toxicity and good local recurrence, recurrence risk avoidance. So this here sort of shows some of the recent studies of reirradiation, some of the dose ranges, and showing favorable overall outcomes at robust time points. So the RTOG, which is the radiation oncology radiation therapy oncology group, which is sort of the consortia of radiation oncologists and others across the country who run clinical trials, started a clinical trial looking at the use of repeat breast irradiation. And I think that was largely because there was enough interest to justify it. So basically what they did was they looked at women such as we're talking about, who were given a repeat course of radiation. The difference was, in this case, it was partial breast irradiation, but given twice a day. And there's some biological reasons why that might be effective, both in terms of the tumor, but also in terms of side effects, and that's the reason they chose that. You can see their eligibility, meaning the patients who could enroll, were actually pretty broad. So they had less than 3 centimeters, not less than 2 centimeters I showed before. No tumor on ink, meaning that they didn't have positive margins. Less than 3 lymph nodes with no extracapsular extension, which is actually kind of interesting. So if they had patients who potentially had 2 positive lymph nodes, and we'd think about doing a lot more stuff, and there were even women who had lymph node positivity who were included. Couldn't have skin involvement, and he needed to be at least 1 year, not 4 years post-treatment. So a reasonable catchment of patients. They were given external beam-based partial breast irradiation. This was presented at ASTRO, which is our major annual meeting in 2015, and reported, showing good toxicity outcomes, and we're awaiting reports on the other endpoints. The subsequent slides, which we won't go into, show some of the patient characteristics for those who are interested. We won't go through that. But again, kind of getting back to some of those numbers regarding the grade of toxicity that I showed before, I think the big takeaway here is that across all these different things that could happen, very few of them actually did happen. Now, you did have some expected side effects in the skin and in connective tissue that tended to be minor, at least on this time scale. So overall, I think that's very encouraging that this is an effective technique. And then as this study reports more long-term outcomes and also survival outcomes, I think we'll have even more. Well, I think this conversation will be more commonplace than it is today. There are 2 other prospective studies, meaning studies that were kind of looking into the future as opposed to looking backwards, patients who they enrolled. One was in Vienna, the other was in New York. Both were treated with brachytherapy. So I've listed both of them here. So the idea of putting radiation on the inside, but still partial breast. And you can see that in the Vienna study of 39 patients and the Beth Israel study, which is a smaller study of only 15 patients, a good overall toxicity, but very good outcomes in terms of overall survival and local control. The next few slides show some retrospective data from some different institutions. The University of Pittsburgh one is probably the largest of them. And these are women who got repeat external beam-based radiation just to the operative bed, so partial breast irradiation. But they got sort of a full course of second radiation to that operative bed. You can see that among the women who got this treatment the second time, most of them had an invasive recurrence, some had DCIS, some even had positive margins. Overall, the in-breast tumor recurrence rate was 20%, which actually is a bit higher than some of the other studies. But notably, the women of these women who got breast cancer on the other side, the rate was 20%, which is actually a lot higher than usual. So it suggests that this is probably a higher risk population. Overall, good outcomes. But a third of the patients in this particular group did have an obvious deformity, which is, I would say, less common. French study, which also is prospective, of only 15 patients, looked at using brachytherapy, that internal radiation, to about 15 patients. For the sake of time, I won't go through too much of some of the retrospective data, but suffice it to say that there are good data looking backwards also of the use of repeat partial breast irradiation, this being a 217-patient study from France. Shorter follow-up, but good outcomes. And also a study from Colombia looking at the use of intraoperative radiation, so 12 patients who got 1 shot of radiation while they were asleep in surgery, and there were no grade 3 or higher toxicities. I alluded to hyperthermia, this idea, excuse me, that increasing temperature may make some of those cancer cells more susceptible to killing by radiation. And there are different ways to be able to do that. Sometimes they'll actually even wrap patients in these sort of blanket type things that heat up their body temperature, which, take that for what it is. But there are multiple examples of this, and this study that is listed here is actually what we call a meta-analysis, sort of an amalgamation of 5 or 6 different studies that were done using hyperthermia that show good outcomes for using it. There is more skin toxicity though, and so it's not a free lunch in terms of you can get a more intense treatment to the breast, but the problem is that you can't get that for nothing. There, at Astro this year was a report using reirradiation with protons. And you see here that this appears also to be an acceptable level of toxicity, and the follow-up for this are still maturing. So I think the initial studies, at least from my perspective, have given a couple of sort of takeaway points. One is, I think it can be done safely. Two, that both in terms of the cosmetic outcomes, but also in terms of the survival outcomes, this is an option, I think, that really is starting to come more and more into vogue, and that we're going to see discussed more and more going forward. And I think because of that, and because the data are maturing, that we are sort of on the leading edge, I think, of really looking at this as a mainstream technique. So I'm going to shift gears for the last couple minutes before we sort of shift into questions to talk about the management of breast cancer recurrences outside the breast. So one is in the nodes, and both the axillary nodes, but also in the supraclavicular nodes as well. And just to kind of mention a little bit of how those are managed and the notion of needing to do reirradiation for those. Because I think we need to sort of flesh out the concept of reirradiation, that we're often faced for the same reasons, not just with women who come back with a in-breast tumor recurrence, but women who have been treated before who come back with a local regional recurrence that we have to manage. You know, we're seeing some patients even this week that this issue seems to come up for. And I think really the question that often gets presented is, what do we do and can we do it? So the initial studies on regional nodal failure, so the idea that in women who were either treated initially to their lymph nodes were treated with radiation or surgery, the likelihood of getting a recurrence is actually quite low. It's probably on the order of 1–1.5%, which in the cancer world is about as close to zero as you possibly can get. But if you look at a lot of women over a long period of time, you'll see them. So it's rare. So this is listed as 1–6%, but I'd say it's probably closer to 1–2% of recurrences. And this is really where it's critical, I think, to obtain your care in a multidisciplinary setting, right? The ability for the surgeon to be able to talk to the radiation oncologist, to the medical oncologist, to put their heads together, to talk with you, and to think about options. And I think it's sort of an iron sharpens iron situation. And so basically how you manage these patients typically is to do surgery first, as we do in initial breast cancer axillary masses. But it really does depend on whether or not they got an axillary dissection first. And one of the things that's happened over the years is we used to, for a large proportion of patients, do pretty significant surgery to the axilla to take out those lymph nodes. And over time, in the same sort of way that the mastectomy story has evolved, we're doing less and less axillary surgery. So in the past, whereas more of those patients got axillary dissections, fewer of them today have had axillary dissections. There are several good studies supporting the use of repeat sentinel lymph node evaluation. If they've had an axillary dissection, that clearly is more difficult. So overall, studies, and I'll kind of move on here, have really shown that by kind of using all three modalities, so basically using radiation, surgery, and chemotherapy, that these patients do better. So basically the treatment approach is to do surgery, and then typically actually radiation is given before chemotherapy in this context, although I don't think anyone's really looked at one versus the other. In the sort of normal context, the kind of upfront context, there are good data for using radiation first and chemo second, or vice versa. We oftentimes do chemo first, then radiation afterwards. Typically, we will give full nodal irradiation, but if they've had it before, we oftentimes will not give a full course of nodal radiation the second time. We may give either an abbreviated course or a much smaller field. Supraclav. So the supraclav, remember we talked about the axilla being the area under the arm. The supraclav is the area just above the clavicle. It also is on that highway system out of the breast, but it tends to behave a little bit differently. And I think some of the original studies looking at recurrences in the supraclav have sort of shown that these behave more like what we call METs, metastatic disease, the idea that you have disease outside of the breast. It tends to be a kind of more ominous sign than an axillary recurrence. However, there are some, and I've kind of listed here in the butt here, there are some data to suggest that if you do sort of a similar, what we call trimodality, using all three methods approach, that you might be able to actually bring that recurrence risk back closer to what you would expect with an axillary recurrence. The mainstay, of course, as is the case with disseminated disease, is chemotherapy. And we try to use that first, and then considering a local therapy like surgery and or radiation afterwards, really sort of the name of the game here. I want to spend just about a minute or two here talking about the role of chemotherapy in recurrent disease. So the question is, up front, when a woman has early stage breast cancer and surgery is done, you often will hear about the use of the Oncotype test, the concept of testing that tumor to see does something more than just radiation afterwards need to be done. So some women after early stage breast cancer will get chemotherapy as well. The question is, if you get a second cancer in that same breast, does that argue in favor of the need for chemotherapy in that setting? Now, the Oncotype test probably does not apply in that context because the women who were included on all the studies that looked at the use of Oncotype had primary cancers, not secondary ones. But there was a study, and I'll show some of the data here. This was presented at what's called the San Antonio Breast Conference back in 2012 that actually looked at women who had recurrences and asking the question, is there a benefit to the use of chemotherapy? And I'll say, the big picture takeaway, and I know that I'm kind of seeing eyes glaze over a little bit, that at this point in your nice comfortable chairs, I would just focus on the very first sentence, which is just to say the role is controversial, but there is a suggestion that some patients may benefit. And this again speaks to the concept of multidisciplinary evaluation. This study basically looked at women, like we're talking about, women who had initial surgery, they had radiation, and then they got a recurrence. So all these women got whole breast irradiation. And then they looked at, if we gave chemotherapy, do some of those women do better than not? And this is called the CALOR trial, which stands for chemotherapy after recurrence. Or we'll see that on the next slide. Anyway, takeaway was that there was a benefit to chemo seen most in the ER-negative patients, so the patients who didn't have a hormone-positive recurrence but had a hormone-negative recurrence. So what you see here is, and these are just slides from the actual conference, so these are not my own, but basically showing that there's an improvement in what we call disease-free survival, so the idea of living without cancer, right, at 5 years in patients who got chemotherapy versus those who didn't. But if you kind of stratify the patients based on whether or not they had ER-positive versus ER-negative, hormone-positive or hormone-negative tumors, you can see that in this case, the red line are the ER-negative, the proportion of patients who are ER-negative who got chemo versus those who were positive. Those patients did significantly better on the long term, and these lines are continuing to diverge, suggesting that the results, I'm just going to go back, the results on this slide may be driven more by the ER-negative patients than the ER-positive patients. So the takeaway, I think, from there is if you have a recurrence, and it's sort of an angrier looking recurrence, maybe it's a hormone-negative one, maybe it's triple-negative, that the consideration of use of chemotherapy is employed. You will sometimes see HER2-positive recurrences. And we have a patient on treatment now who had a HER2-positive recurrence. And in those cases, those patients will get chemotherapy in addition to radiation and surgery. So for many of the folks in the room, you may be familiar with kind of how we give radiation. But I'm sort of wanting to switch gears at the very end and just kind of give you a sense for how we think about radiation as radiation oncologists, some of the options, just to kind of finish up our talk here. There's really no lacking with respect to the number of different types of radiation treatment schedules that we can use. And some of these you've seen here, maybe have personal experience or know people who have gone through radiation 6 weeks, 4 weeks, sometimes shorter. And this choice is based on a variety of factors. There's some patients who are really better suited for one versus the other, either based on what their breast anatomy is, maybe the type of surgery they've had, maybe their prior experience, maybe whether or not they've had an implant. But for the most part, I would say that many of these whole breast techniques are pretty much applicable to most of the patients that we see. And I've listed this here just to kind of just to sort of contrast what we call accelerated partial breast irradiation, where we kind of give radiation in the upfront setting to just the tumor, and that is an option for women who present with early breast cancers, and we'll give that in as short as a week. Now, when we give radiation the second time, we don't do accelerated partial breast, we just do partial breast. So we do the same area, but just over a slightly longer period of time, just to try to keep it a little bit more gentle. Some of the technology that we may use to position patients when they get treated. This is an example of what we call a breast bore, where a patient lies and their arms are above their head here and the machine is open. This is what we call a prone breast bore, where patients lie on their belly and their breast falls through. And depending on the center and the patient's anatomy, one may be chosen over another to help with treatment planning, to help with side effects, to help with sparing of other important structures underneath, like the heart and the lungs. When we actually go through and do treatment planning on patients, part of what happens between when a patient comes in and when a patient gets treated is a very detailed process of calculations and sort of decision-making with respect to making sure that what needs to be treated is treated and what doesn't need to be treated gets as little treatment as possible and that it is safe. So this gives you an example of what often is treated when you treat the whole breast, which of course is the whole breast, but what sits behind it, the heart, the lungs. But you can contrast this to the use of partial breast, where we would just treat the area where surgery was. And this is often aided by the use of surgical clips and other localization devices. But the idea is that the area that we treat is significantly smaller than what we treat the first time. And so this is where an external beam-based approach or brachytherapy might be employed to just treat what we see in the yellow circle as compared with the red. There are multiple techniques for delivering it. I mentioned this before. Some of these look a little bit less pleasant than others, but they all have different advantages, right? So this is the use of catheters, the idea of actually putting in these plastic tubes and you can temporarily put radiation in there. This looks pretty barbaric, so I would tend to agree with it by looking at the picture. And honestly, I think that wouldn't be my first choice personally, but at the same time, you can get very, very nice dose distribution, meaning that you can treat just the area that you want to treat with sparing other stuff. So there are some advantages there. These show pictures of intraoperative radiation. The patients are asleep. And this is an example of balloon-based brachytherapy, which we'll see on the next slide. And there's external beam-based, where we actually just use X-rays on the outside to just treat what was the yellow circle on the prior slide. I just put up some of the terms here that you probably have seen for how brachytherapy can be delivered, and both around town and elsewhere. These are just different techniques for doing the same thing, right? These are just different. This is like Toyota versus Honda, right? They're all cars, but it's just a different brand, different way of skinning the cat, basically. So overall, just kind of wrapping up, big picture here that based on our current data, that 1 in 10 women will experience a second cancer in their lifetime. I think this number is probably an overestimate today. The number is probably a little bit lower than that, but I think that but this is an issue that's not uncommon. Based on the data that we've seen, I didn't really look at the calculation this way, but if you look at the local control rates, 75% of women who undergo repeat breast-conserving therapy may avoid a mastectomy the second time around. Not that mastectomy is a bad thing, but if they want to avoid a mastectomy the second time around, 75% of them can, which I think is a point that may not be well known. Repeat breast-conserving therapy can be delivered safely with a favorable side effect profile. Outcomes data are still maturing, but what we do have are very encouraging. Nodal post-mastectomy recurrences and other more advanced recurrences do require multidisciplinary evaluation. So my practice personally, kind of how I sort of think about it is, and one of the great things about how our practice is organized is that we do have that sort of multidisciplinary evaluation built in. So really, it's for every patient, early, late, really kind of thinking through every single patient. And I bring that up because I think in sort of offering these different treatments to different patients require a level of comfort on the surgeon's perspective and a level of comfort on the radiation oncologist's perspective. So for me personally, I think a smaller in-breast tumor recurrence without nodal disease, at least 1 or 2 years, typically 2 years post-treatment, would be sort of the ideal patient to get reirradiation. And I'll typically do twice daily radiation based on the R2G 1014 data that I showed. But there are some women who still want to come in once a day because twice a day is kind of a pain in the butt. And so we do sometimes offer the once daily option. even women over 70, I think in this context, there are some women in the early stage breast cancer world the first time around where we can omit radiation if you're over 70. But if it's the second go around, oftentimes I think the threshold is lower to give radiation. We will offer post-mastectomy radiation again if it can be done safely. And in most cases, it can be. So with that, I will stop with this picture and be happy to take any questions. Okay, these are great questions. Okay, so first question, excuse me, is hypothermia the same as cryoablation or cryotherapy? No, it's not. So cryoablation is actually kind of taking the temperature the other way. So it's sort of freezing those cells. Hyperthermia is sort of raising it. So there are other techniques, cryoablation and other types of ablative techniques that don't have the same level of databases for them. And I think my view on them personally is just that they can make sort of conventional therapy a little harder. So it's not to say that there aren't potentially in every disease site other possibilities that are out there, other new technologies that are still emerging that may one day be part of our treatment paradigm. But I think in the short run, for some of these patients who need to kind of get back on the tried and true path, it can make it a little harder to go back and manage those patients. I hope that answers that question. Next question here is how often or what percentage of people will have heart or lung complications after radiation? How much higher is this number with radiation? It's a great question. It all depends. So in the first round, it all depends on how the radiation is given. But there has been a much higher level of energy and insight sort of paid to heart and lung complications because breast cancer survivors do on average tend to live so long. I would say that in women who have, and some of these data are older, but in women who have a limited cardiac history with good sparing techniques, the likelihood of any what we call excess risk due to radiation is probably less than 5%. And with women with more cardiac history, there was some thinking, and there continues to be, that risk may actually increase by about 7% per gray, basically per mean. It's sort of it's the unit of radiation that we give, mean heart dose to the lung. It's hard for a patient to sort of evaluate that because they don't exactly know what the mean gray that their heart is getting, but certainly talk with your doctor about it. What I would say is there's a lot of attention paid to cardiac sparing techniques, to lung sparing techniques. The heart and lung are pretty hardy when it comes to radiation in the short term. And also on the long term, with appropriate techniques, can be spared pretty effectively. In the re-irradiation setting, because we're treating a very small area and the heart dose is pretty low, while the additive heart dose is not zero, at the same time it's not crazy high. It's actually pretty low. So I suspect this will be an area of further study in the future, but my prediction is that that rate will be reasonably low. DCIS oncotype, good question. So the oncotype test for invasive cancer was developed to basically what it does is it takes out when the surgeon takes out the tumor, they send it off to a testing facility and they look at a bunch of different genes because basically when we look at breast cancer cells now, you look at it under the microscope. So it's kind of like a spy plane, right? It's kind of like a U-2 spy plane going over a city, and you're kind of taking pictures and looking at the city saying, well, what's going on here? And you're trying to get a sense for what's happening, right? What the oncotype test is basically doing is kind of breaking those cells apart and looking on the inside to see what are those cells doing, like really doing and behaving. And it assigns a risk score, and that risk score can help in decision making with your doctors for what kind of treatment's involved. And it's been a very useful test because it's helped to, in a particular subset of patients that we see, which is actually a pretty large subset, it helps to make some decisions regarding things like chemotherapy. Now, because of the popularity of that and the utility of that, there has been an interest in trying to apply that technology in DCIS and actually in other diseases like prostate cancer and whatnot. I think we will see more of that. DCIS oncotype has been popularized. There have been some initial studies. Those data are maturing. We are still clarifying as a field how best to use that in treatment decision making. So my best analogy for this is, because a lot of patients will come in and they'll say, well, I just want to know what my score is. And I'll say, yeah, so do I. But then the question is, what do we do when we know that score? And it's not to say that we should or shouldn't act on it, right? But it would be sort of like saying, well, let's go in this room and figure out the level of some protein in our blood. Okay, that's great, but what does that mean, and is it actionable? And I think we're starting to get more information on the answer to that question, but at this point, in terms of from a radiation perspective, and from a medical oncologist perspective, we're still kind of working on exactly what to do with that. I'd say hopefully that's a fair answer. Is it true you cannot have reconstruction after radiation? No, it's not true, but it is, and we do see this, but it can be harder. So, and it all depends. I think that we, in general, and I think that the bias that Dr. Dunham spoke about is really great to think about in all aspects of life, but particularly even doctors have that bias too, right? When we think about decision making, we sort of think about the extremes oftentimes, right? The patients who did really well or really badly. And we sometimes will see this in other specialties too, right? And so, and that sometimes impacts how we present information to patients. I bring this up to say that you want to be able to get advice from people who understand what you're thinking and to try to help you get where you want to go, within parameters, but to help you get where you want to go. So it's not to say that it's impossible, and some folks will do it, but, and Dr. Dunham, who's here, can speak to this better than I can, but what I will say is that it's definitely harder than, it's better to know up front that you want to do it, but it's not impossible. So that's what I've got here. Are there other questions in the room or anything else that we can help with?
What is the magic age of 70 about?
It's a good.
Is that in the literature all the time?
It's a great question. So the question was, what is the magic age of 70? And yeah, forgive me for those who are 70 or older, right? There's nothing magical about it. The medical profession doesn't think differently of 70-year-olds versus not, right? But there were some studies that were done by some cooperative groups over the years that kind of looked at, what we did know was that younger women who had breast cancer by decade, so if you're in your 20s, your 30s, your 40s, and going up, as you go up, the breast cancers in general tend to behave less aggressively, right? So if you get a breast cancer in your 30s, this sort of makes sense. But when you're in your 30s, it tends to be worse than if you're in your 40s, and so on and so forth. So the question is there some age where we can start de-intensifying our treatment? So basically not doing radiation or not doing chemo or not doing something. And so there were some studies that looked at women. They just kind of had that arbitrary cut point of 70. And they said, well, are women who are older than 70 versus younger than 70, can we omit radiation, for example? And there are other disease sites too, brain tumors and others, where we kind of look at different cut points. In the case of the brain is 65. Nothing magic about those numbers. I think it all depends on the fitness of a particular patient. The magic age of 70 in some of those trials, though, did show that in certain types of women who had certain types of tumors, certain sizes, if they met certain criteria, we could omit radiation. And so we don't, as doctors, really don't want to be doing treatments on patients when they don't want it and we don't want it and they don't need it, right? And it's a cost to them, it's a time to them, there's toxicity. So we are also looking as much as patients are for when can we do less, when do we need to do more. And so that 70 number does seem to be a cut point for when we don't need to do as much. The first go around. The second go around, we just don't know the answer to that. Now, if you're over 70, you may have the body of a 60-year-old, right? Or if you're 40, you may have the body of a 60-year-old. And so those decisions are somewhat based on the number, but also based on those other factors that are unique to you. Other questions? All right, well, thanks for your attention, and I hope you have a good rest of the conference.